Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh.
Welcome to the lecture on Chapter 3, a historical overview of U.S. healthcare delivery. In this lecture, you will see how it got to be the way that it is.
Chapter 3, Historical Overview of U.S. Healthcare Delivery. Learning Objectives. At the end of this lecture, students should be able to name at least 3 characteristics of healthcare delivery in pre-industrial America, name at least one notable development in medicine in the U.S. in the post-industrial era and describe why, explain at least one reason why national healthcare has failed in the United States, and describe at least 2 differences between Medicare and Medicaid. Today's U.S. healthcare delivery system is complicated, and it doesn't make a lot of sense in some places. Some places it contradicts itself. In some places it seems downright ugly. In other places it seems pretty cool, and it's kind of nice and interesting. It's definitely too expensive. But in any case, we all sit and look at it and we wonder how it got that way. Well, knowledge of the U.S. healthcare history is really necessary for understanding how it did get that way, for understanding all these contradictions in our systems and all these tensions. The system's historical foundations have explained why, for example, America has resisted universal health insurance, even though it seems to look like a good deal, right? Because we have all these other comparisons to look at. Despite many forces of change, healthcare still is a private industry, and it's still receiving financing from the government in the U.S. And when you think about it, that should be pretty objectionable to people in the U.S. Why should we make these businesses and just fund it with the government? Why don't we fund it with actually individuals, the way you would fund a car dealership or a yacht place where individuals just buy stuff? So ironically, despite private and public sources of financing and all the money that is spent, at the end of the day, many people in the U.S. still go without health insurance, and therefore they have no access to care. So there are some major forces of change in healthcare delivery, especially going on right now. Our cultural beliefs and values are changing. Remember how I talked about the original ones we've had of self-reliance and welfare assistance only for the most needy. We ourselves are tough. People who often have Medicaid may not use it because they feel like, they don't want to be on the public dole. However, now that a lot of people are on the public dole with the recent recession, some of these cultural beliefs and values are changing. They're also just simply social changes with demographic shifts. As you can see by this photo, now men can get married to other men, at least in Massachusetts where I am, and women can get married to other women. The LGBT community has been shut out of healthcare in many places. That community has unique health needs that now will need to be accommodated. We need to look at immigration. Who is immigrating? From where? And what is their health status? How is it contributing to the community? And how do we need to protect these people? Also, just further urbanization, people coming to the city who weren't from the city. And then, of course, we still have technological advances that march on in the U.S. and throughout the world, but especially in the U.S. We are always generating new treatments, training, and coming up with new kinds of healthcare professionals. And we're also always having to update and rebuild and even build new facilities and get new equipment. There are economic constraints. That's one of the major forces. In the past, we've sort of avoided that for different ways, but now it's really coming to bear. Healthcare costs are just astronomical now, and so are health insurance costs. Family incomes have gone down. These major forces are really changing things. Also, political opportunism. If you simply looked at the news for the last 10 years, there would be years where the words healthcare system just didn't show up as much. However, in the year 1997, when some legislation was passed under President Clinton, you really heard a lot about health care. And now you're hearing a lot about it again. It really matters what the president's agenda is, even though so far all the he's who have been president haven't been able to push anything through, and the one first lady who tried, Hillary Clinton, really got a lot of rotten fruit thrown at her. Domestic and foreign priorities also sort of push around health care in the United States, as well as party politics. You've got the power of interest groups, like the famous Tea Party saying of wanting government to get out of Medicare, and then you've also got laws and regulations that come to bear. History leads us to the present. We have science and technology that has advanced to the level where U.S. is highly specialized in that area. So that's kind of cool if you're from another country and you want to come to the U.S. and get some of our highly technical medicine. But if you live in the U.S., basic and routine care is given secondary importance and you may be going without it. Providing the latest treatments, which are highly used by the population, is also kind of cool, but it really increases the cost of healthcare overall. And as insurance is extended to more Americans, that cost must be contained. In other words, providing these latest and greatest and expensive treatments, it just can't go to everybody. So let's look back to medical services in the pre-industrial America. Healthcare delivery in pre-industrial America. I want to remind you of the time. We're talking about the middle of the 1800s, before the Industrial Revolution. We're talking about the time of the Civil War. Medical training and education were not grounded in science, especially in America. America was barely born. Primitive medical procedures were practiced, and also intense competition existed because any tradesperson could practice medicine. People relied on family members, neighbors, and publications for domestic remedies. For example, imagine living in a farm in Minnesota or North Dakota or Iowa at that time. Family members, especially female family members, would help with birthing. Neighbors and family members would help with taking care of sick people, trying to diagnose them and coming up with remedies. And also publications were made so that these people could be aided by the information in the publications, especially about nutrition and remedies. Physicians' fees were paid out of personal funds. Rarely were physicians called in, but if they were, a pool was made of funds and cash was paid. And healthcare really was delivered in a completely free market. You could choose which physician you wanted because you were paying out of your pocket. Hospitals were few and far between, located only in big cities. But at that time, unlike today, most of the population was not in a big city. Hospitals at the time are nothing like hospitals today. Today, we look at these fancy, beautiful buildings that are clean and full of amazing professionals. At that time, hospitals were sort of seen as icky. They had poor sanitation, the staff were unskilled. They were sort of seen a lot like the mental hospitals of before the 1980s when they were closed. Almshouses at the time were created to serve the destitute and disruptive elements of society and provided some basic nursing care. This might call to mind the idea of the correctional institution we have right now, where most of the people who are inmates have severe mental illnesses. Those places for the destitute and the disruptive elements of society do get some basic nursing care. State governments at the time of pre-industrial America operated asylums for patients with untreatable chronic mental illness. These efforts later grew into state mental hospitals. Pesthouses quarantined people with contagious disease. Remember, penicillin was not invented until the 1930s. So at the time of pre-industrial America, when people got contagious infectious diseases, the best way to deal with it was to keep them away from other people. They had figured this out, and they created pesthouses for it. Also, there were dispensaries, and they delivered outpatient charity care in urban areas. those are kind of like what our community clinics are now. Medical training was different in the pre-industrial era. Until about 1870, medical training was through apprenticeship, much like plumbing training and other apprenticeships are done now, where one person is paired with a student and goes around showing them the ropes. Ironically, those at the time who were doing the training were themselves poorly trained, because remember, there really weren't any medical schools. However, those who were training people were also offering services and charging for them, the training, and they found that training an entire class could make more money than just training individual apprentices, so they tried to open some schools. It's hard to have a medical school if you don't have all the equipment and stuff to train the people on, so lack of facilities and the ability to give actual degrees prompted these physicians to try to affiliate with local colleges. So in 1850, there were about 42 of these medical schools. Now remember, these people who were founding these medical schools were not really trained in any medical science because it really hadn't become an organized field. In other words, at that time, there was almost nothing to learn about medicine, so it really didn't take that long. In the first year of medical school, you would attend 3 to 4 months of courses, and in the second year, you'd repeat the same courses, and after 2 years, maybe graduate with a 2-year medical degree. Of course, all along doing the apprenticeships and going to people's homes and learning about how to treat them from the person you were paying. So it is hard to even imagine that this is how medicine started in the United States. Back then, anyone could practice medicine, and the medical procedures were primitive. There was really no rigorous course of study or standardized course of study, and most physicians had little actual expertise. Because of these things, it is not like it is today. If you learn that somebody in your family is becoming a doctor or going to medical school or someone's marrying a doctor, everyone becomes excited with the prestige. But of course, if you have a situation like we had in pre-industrial America, where blacksmiths and barbers are becoming doctors on the side, you end up with more of a low status job, often a side job for extra income. And so, therefore, if you were a family and you had to consume medical care in the U.S. healthcare system in the pre-industrial era, you would prefer to rely on yourself. You could not afford the physician's fees anyway, and besides, what were you buying? In the United States, there were just a few hospitals in the pre-industrial era. Those were in New York City, here where I am in Boston, in New Orleans, St. Louis, and Philadelphia. And if you remember, not all of the United States had been put together by then, so there were simply places that weren't part of the United States, so they couldn't have United States hospitals. Those few hospitals that existed really don't look like the hospitals today. Although a few old hospitals from Boston still survive, they've been completely rebuilt, because back then they were unsanitary, had poor ventilation, and were unhygienic. Remember, they had not really understood the importance of hand washing and sterility at that time, so it was easy to let things get dirty. Nurses were unskilled and untrained, just as the doctors were semi-untrained, and it was really more dangerous than staying home. They were seen as houses of death and institutions of welfare. However, at the same time, in Europe, France and Great Britain expanded hospitals. They did that long before the 1800s, and the medical professions readily adopted new science. A lot of people don't realize that before the United States was seen as the medical research advances leader, it was France, Great Britain, and even Germany. Let us play a little pre-industrial medical institutions mix and match. Remember the almshouses and the poorhouses? Look at the left side of the slide and see them as number 1. On the right side, what matches them? The almshouses served elderly, homeless, orphans, ill, and disabled, those who really couldn't help themselves. However, the residents were called inmates, and so you can kind of imagine what it was like. Now let's look at the asylum. What was the asylum again? The asylum was for patients with chronic, untreatable mental illness. They used the latest treatments, such as bleeding, forced vomiting, and hot and ice-cold baths. It's a lot like today's correctional system without all of the bleeding, forced vomiting, and hot and ice-cold baths. Pesthouses, again, had the goal of containing the spread of communicable disease and served people with cholera, smallpox, typhoid, or yellow fever. Do you remember what the dispensaries were? These were often staffed by medical students, and this place provided the drugs to patients. So already, big pharma was little pharma. Outpatient clinics were the dispensaries who provided the free care to those who could not pay. Let's now turn our attention to medical services in the post-industrial America. So this is in the aftermath of the Civil War, and there were changes everywhere. Let's start with the changes in the medical profession. In 1840, 11% of the U.S. population lived in urban areas, and in 1900, that increased to 40%. So imagine that almost 90% of the U.S. was in sort of a rural area, likely to be farmers or to be living in small towns serving the farming community. So as those people left their farms and came to the city, how was their health care changing? How did this change family-based care? How did this change where medical services were offered? So things became increasingly driven by science and technology, which was more easily available in the urban area. For example, a good effect of this was X-ray technology that really helped with diagnosis. However, it costs to run an X-ray machine. Even though it doesn't cost as much as maybe an MRI machine, there still is a rise in cost. Also, there become some questions a lot of people don't think about. Who deserves an X-ray? When do they deserve an X-ray? When is it better to not give an X-ray? After all, you can get exposed to things by having one. So we sort of think in the U.S., just because an X-ray exists, we should have one. But we don't realize that maybe there are some penalties to that. There are pressures of science and technology, and those led, back in the day, to pressures for physicians to specialize. So, in the post-industrial era, physicians started trying to think about being in special different categories or specializing in certain areas. Now it became a little harder for the family doctor to be the family doctor. Think of the implications for care coordination. Here is a brief slide on post-industrial groundbreaking medical discoveries. This is where we learn about hand washing. This is also where we learn about penicillin. We can start attacking a lot of those infectious diseases. We can start preventing a lot of infections both inside and outside of the medical arena. We learn how to pasteurize food to kill bacteria. As I mentioned, the advances in X-rays and other diagnostics, and also anesthesia makes it easier to do surgery. So in addition to those changes, you have changes in doctors specializing, you have changes in what doctors can do, so you have changes in the American Medical Association. So since 1847, which was the pre-industrial era when the AMA formed, that in that era, AMA took a back seat to uncoordinated actions of individual physicians competing in the marketplace. In other words, it was a completely free market back then, so the AMA was just kind of like this club. But during the post-industrial era, they really got to organize. They organized members into state and county level societies. They started controlling medical education. And because they were doing that, then they could lobby states for medical licensing laws. They could say, hey, we're controlling the standards of these medical education, therefore we should be the ones to decide if somebody is properly educated and can practice. Further, they discouraged corporate control. Again, like even in the pre-industrial era, they wanted the physicians to be able to be individual entrepreneurs in the marketplace. And they didn't want to see them working for hospitals or insurances where they would make less money and they would have all these constraints. The AMA succeeded, and in already, this post-industrial era, they got legislation passed such that prescriptions then required a physician authorization. They also got it so that health insurance would only pay when prescribed by a physician. Remember, these are things in the U.S. that we just take for granted, but this is when they started, really a long time ago. Now let's play a little more mix and match, only this time about the post-industrial era. Look at the Howard University School of Medicine. In 1869, what did it do? Well, it and also the Meharry Medical School were established to prepare black physicians to practice medicine. You probably wonder, why do black physicians have to go to a different school than white physicians? It is because of racism. Next, we have the Harvard Medical School. What did that do in 1871? That changed the academic year to follow the European model. Remember how Europe was already pretty advanced with their whole medical systems. Now Harvard was getting in step. Johns Hopkins University also made some changes in 1893. It changed the entrance requirements to medical school to include an undergraduate degree, not just a high school diploma. This is not true today in all countries. In the U.S., this continues to be true. But where my father's from, in India, people today can get an undergraduate degree in medicine. However, they cannot practice in the United States unless they go through more training and more apprenticeship, such that they are equal to the training that we expect here. In 1910, the Flexner Report came out, and what it said was it found widespread inconsistency in medical training. Well, it kind of makes sense. If black people have to go to their own medical college, already you've got a problem. In 1910, which is the same year as the Flexner Report, the Council on Medical Education was formed by the AMA, maybe even in response to all these calls, and it pushed for state laws requiring graduation from medical school for licensure. Again, getting organized and lobbying Congress and the U.S. President. Also in the post-industrial era, you have further development of the hospitals. Industrialization of medicine. Now remember, in the Industrial Revolution, what happened was people went from making things in a craft area where maybe somebody would sew a bunch of clothes to making things in a factory where everybody was on a factory line. Well, this kind of happened with medicine, and it had to. The physicians could no longer afford equipment and facilities. Things just got too complicated. And hospitals were set up, but they didn't have any physicians there. Remember, they were encouraged to compete in the marketplace, and the AMA really kept them out of being hired by hospitals. However, they needed them to come to the hospitals and work there, or their beds wouldn't be filled with the physicians' patients. So from this, informal alliances between physicians and hospitals formed. The physicians were not employed there, but had a strong say in the hospital operations. If you work at a hospital, you will see this, even today, in that a physician organization usually is what pays or is the payroll for all the physicians at the hospital, but everybody else works for the hospital. As more hospitals became available in the post-industrial era, competition for physicians' patients started to influence hospital policy. So, for example, if Dr. A brought more patients to my hospital than Dr. B, then I would like Dr. A more. And in fact, if Dr. A wanted me to give more pain medication in my hospital to the patients, I probably would do that just to satisfy him, because at the time they were only men, and then that way I could get more patients. This slide shows a summary of some notable developments in the post-industrial era. First, you have urbanization, as I mentioned before, but you also have scientific discoveries and applications of those in medicine. You have advanced science-based treatments, but of course these increase healthcare costs. And now, with all the specializing, with all these advanced science-based treatments, you start to get this growing imbalance between specialists and generalists. Specialists can charge more for their fancy contraptions, and so doctors start wanting to be specialists more. You have medical education reform and the increase of power and prestige of physicians. This was all precipitated by organizing medicine. The AMA really organized people in the medical field. It seized control over medical training and standardized it. It became a powerful political interest group. Now physicians could support licensing laws, and they could put up opposition to national health insurance proposals because they felt, as independent entrepreneurs in the market, they could make more money without it. So this organized medicine then continued to support the private entrepreneurship in medical practice. This is when hospitals became true medical care institutions and went from being dirty places where people avoided because they were afraid they would die. And also in this environment was the creation of Medicare and Medicaid. We continue on now with the history of health insurance because now we have the birth of health insurance. Before we just had health care and now we have insurance. So we have some early blueprints for health insurance. The first one is workers' compensation. In 1910 to 1915, a lot of laws were made and it opened the idea for government-sponsored insurance. People really felt that the American worker who was working very hard should not have to fear getting injured at work and therefore not being able to work and not being able to afford medical care. So we all pitched in as taxpayers back in 1910 to 1915 and agreed that those people should have subsidized health care. But it wasn't until 1940 to 1950 that hospital insurance came about, and this is public insurance. This was when Blue Cross was invented. What happened was a hospital group around a university in Texas decided, hey, wouldn't it be just cheaper, since we have all these professors and these students at this university and we have this great medical school and this great clinic hospital system, if we just simply do away with these individual billings and just make everybody pay insurance premiums and then they just have to use our services. After all, it was easy. They were right there on campus. So that was the birth of Blue Cross, but then you have to imagine that model. How easily does that work if you try to expand it to a bigger community or maybe even the United States? Later, not much later, you had the birth of Blue Shield, and that was independent of the birth of Blue Cross. That didn't really focus on hospitals, that focuses on going to the doctor's office, the physician fees. It actually wasn't until 1974 that Blue Cross and Blue Shield started to merge. There started needing to be more of an integration between what was going on in outpatient and what was going on in inpatient. So then we had the graduation of this outpatient sort of insurance and inpatient sort of insurance to this combined employer-based health insurance. And this started in World War II. Remember, the early 1940s is about that time, as part of preventing inflation, oddly enough, and laws were passed in 1948 and 1954 reflecting those values. Now we come to the emergence and rise of private health insurance. The emergence was actually rather early. It began in the 1900s to guard against unexpected disability, sort of seen as catastrophic insurance. Even in the early 1900s, in some places, medical care had become a more entrenched way of life, and it also was too expensive, and people knew this. And so if you worked on a farm and you made enough money, you might buy this private health insurance. But starting in 1916 to 1918, a lot of unsuccessful attempts were made to compel employers to offer health insurance by legislation. This is what is done in some other countries, developed countries, through social insurance. Instead, the hospital plan, like Blue Cross, grew out of the dire conditions of the Great Depression. This is to remind you of the fact that the Affordable Care Act is growing out of the dire conditions of the Great Recession we have just been having. Blue Shield, which covered physicians' fees, started in 1939 and merged with Blue Cross in 1974. So now you had this combined insurance available, but it was private. And this employer-based health insurance started in World War II and then subsequently was actually enshrined in law in 1954. So insurance almost had to be invented first before the employers could really try to offer it. Now let's talk about national health care in America. It's been talked about a lot recently, but who brought it up first? Was it recent? Well, during World War II, there was a lot of anti-German sentiment because the U.S. was at war with Germany. And so, therefore, at that time, people were really against anything German. And remember, Germany had that really good medical research system, and so they also had some pretty good medical care system, which is similar to today's Germany system, which is that social insurance thing. So therefore, in the United States, we learned the word social insurance, and we sort of connected it with Germany, and then we didn't want it. However, FDR came forth in the 1940s with proposals for national health care, and those were all defeated by the AMA. Later, in 1946, Truman tried again. He made a direct appeal for the government plan, but again was shot down. In 1993, Clinton proposed a plan, and he was defeated. So those of you who feel like this is sort of a new idea with Barack Obama, you have to see that it just comes and goes in the U.S. And each time we find some sort of way of getting over a hump. This hump looks pretty big. So up to now, why has national health care failed in America? As I said, it had no real good early footing. We didn't really want to be like Europe, and in the U.S. there was a little political or labor stability. We were a new country. It was decentralized. The government really doesn't control social policy in the U.S. That's why we love the U.S. But at some level, then it can't control our health care. As I mentioned, socialized medicine is a bad name, and the AMA jumped in, and they have always opposed these national health care initiatives because they wanted to promote doctors as entrepreneurs. The beliefs and values of all of America, whether we're patients or providers, is that of capitalism and self-determination. So even patients, for the most part, believe that providers should be able to compete. And also, we have a distrust of big government. We don't want to give all our money to the big government and have them decide where to put it. We are anti-taxes in America. Certainly we agree. We have to pay taxes for certain things. For instance, national defense. But we really don't want to pay taxes for health care. Americans have historically been averse to paying taxes to support national health care. This brings us to Medicare and Medicaid. The creation of Medicare and Medicaid happened in 1965. Before that, only private health insurance was available. So for this period of time when they finally worked out how you could have private health insurance, people could afford it, could get it either through their employers or on the open market, but everybody else didn't have an option. And so they would have to pay out of pocket or not get care. And Americans were against government-sponsored health care, except for special classes, for the poor, and now for seniors. So if you fit into a certain protected class, then you deserve government-sponsored health care. It's just that other classes of people didn't. So the original Medicare bill started in 1957. It takes a few years to do these things. And the AMA really discredited it. I thought it was particularly interesting that liberal Congress people were against it. They said it was humiliating to elders, and states resisted implementing it. I wonder if any of those Congress people would think about this now, if they would look back and say, wow, maybe it's not so humiliating. In 1965, Lyndon Johnson got a lot done. He made it top priority, and Medicare and Medicaid were born together. Medicaid has a stigma class that its sister, Medicare, does not have. That's because all you have to do is to be an elder to be in Medicare. Medicare expanded to cover disabled and end-stage renal disease as well, but to be in Medicaid, you have to be poor. Over the years, both Medicare and Medicaid have caused state and federal budgets to grow astronomically. This means now we're dumping a bunch of taxpayer money into subsidizing health care for people who couldn't have it before because they couldn't afford insurance. In 1997, we had HCFA. Did you know that HCFA is pronounced HCFA? Now it has changed to CMS. That is actually pronounced CMS. It's funny how these things are pronounced differently. HCFA stood for Healthcare Financing Agency, and now CMS stands for Centers for Medicare and Medicaid Services. Now, if you notice, I said CMS, but I said Centers for Medicare and Medicaid, which is two M's. So that's the thing about CMS is it doesn't have enough M's in it. But HCFA is just a word without any vowels. In any case, Medicare and Medicaid brought more regulation. So let's compare Medicare and Medicaid. Please look at all these comparisons. There's differences in coverage, how much is covered, and how much you have to pay. There's differences in income. Obviously, all you have to do is be an elder to be on Medicare, whereas you have to do a means test or be poor enough to be on Medicaid. There's no class distinction again, where in Medicare, whereas you get public welfare and Medicaid, and the services are slightly different that are covered. But what I would say is the most important difference between Medicare and Medicaid is the uniformity. Medicare is a federal program and is nationally uniform. No matter where you move, if you're on Medicare, you will have basically the same health plan. You might have different providers, but the health plan will act the same way. Whereas Medicaid varies from state to state. If you're in a poor state, you won't have it. In fact, you may not even qualify because they don't have enough money. If you're in a richer state, you might be able to. There are more differences. Look at laws. The law that created Medicare and created Medicaid is one off from each other, Title 18 versus Title 19. And also the financing. How Medicare is financed is entirely federal, which is why people fight about it a lot. Medicaid, people fight about too, but the fight is bigger because it's also financed by the states with matching funds from the federal government. And so different things happen in order for states to get more money from the federal government for their Medicaid programs, and some states are better suited for doing that than others. Think about Medicare and Medicaid and think about the differences, and think about the different Americans we have and who might qualify for either. Now we move on to the next era, which is the corporatization of healthcare delivery. In the corporate era, you have corporatization, the information revolution, and you have globalization. Let's start with corporatization. We learned about managed care organizations and integrated delivery systems. That's sort of the higher level of organizing these mini subsystems in the U.S. healthcare system. So since the 1990s, more Americans are part of MCOs, and MCOs are using purchasing controls over the rising cost of healthcare. That is corporatization. They are corporations. And provider groups have developed their own IDSs to minimize the cost of delivering healthcare. So in other words, MCOs have gotten organized into corporations, and physicians and providers and nurses and clinicians and all different kinds of people involved in healthcare have organized IDSs to try and cooperate with these MCOs to minimize the cost of delivering healthcare. And so that's what the corporatization of healthcare looks like. You also have the information revolution going on in the background. You have e-health and you have telemedicine. E-health includes online websites from, for instance, the Mayo Clinic and the National Institutes of Health, as well as medical services offered over the internet. So now, a lot more people than just doctors have access to quality health information. Telemedicine has made it so healthcare can be provided from a distance. So you don't have to drive or sometimes even fly to a place to get what you need. Finally, we have to now contend with globalization. One way globalization happens is through telemedicine. It's pretty easy to deliver care across state or country lines through telemedicine. You also have medical tourism. I recently heard about somebody who went to Lebanon and for $1,500 got a nose job and a trip to Lebanon and stayed in a resort. So you can see why there is medical tourism going on. There's also foreign care provision. Just as the person who went to Lebanon got care from a foreigner, people from Lebanon who come to the U.S. also get care from a foreigner. There's also staff migration. You can't get hired in the United States, maybe you'll move somewhere else. In fact, one of my friends who grew up in the United States moved to Canada to give care there. Globalization, therefore, presents opportunities for cross-border healthcare, but it also presents threats of bioterrorism and cross-border diseases. In conclusion, the pre-industrial era included medical training and practice in institutions that were very primitive. However, things got organized in the post-industrial era. There were notable developments and discoveries. The AMA gained power. There was a lot of educational reform and the further development of hospitals. Then, in response to that, you had the development of health insurance, and that history is interesting. You start with the emergence and rise of private health insurance, and then several attempts for national health insurance that fail. And then finally, we end up with Medicare and Medicaid, which both have differences. We have launched ourselves into the corporate era, full of MCOs and IDSs, and now we have to contend with the information revolution and globalization. We are now at the end of our lecture, and so you should be able to name at least 3 characteristics of healthcare delivery in pre-industrial America, name at least 1 notable development in medicine in the U.S. in the post-industrial era, and describe why. Explain at least 1 reason why national health care has failed in the United States, and finally describe at least 2 differences between Medicare and Medicaid.
Now that you've seen the video for Chapter 3, you understand how it got to be the way that it is. In the next lecture, in Chapter 4, we will learn about the professionals and the providers involved in the U.S. healthcare system and how they cope with it.